Good evening, everyone, and welcome to our second session in our Triage Training webinar. My name's Helene. I'm the Workforce Development Officer here at Western Victoria PHN, and alongside me is Jade, also Workforce Development Officer. I'd like to begin by acknowledging the traditional owners and custodians of our unceded lands and waterways. I'm dialing in from Wadawurrung country this evening. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations peoples and organisations. Just a little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHN Learn YouTube channel. The link is on the screen there and also in the chat. You can also see our upcoming events on the screen, and you can register for these via our website, and the link is also there for you. We're excited to announce our major annual conference has been set, so please save the date for this conference. We've got a great program, and it will be held again at the Good Shed in Ballarat. Please make note of the West Vic PHN health pathways relating to this topic, and they're on the screen at the moment. You all should be familiar with our health pathways, which is a free online resource with localised clinical and referral information for health practitioners. Now, a certificate of attendance will be emailed to all participants. If you could just take a moment to check that your full name is accurately displayed on the screen. If not, or if you are unsure, just rename yourself, type your first and last name in the chat box, and that way we'll make sure we get your certificate to you. And if you could just keep yourself on mute unless you would like to ask a question. We encourage interactivity and discussion, so please feel free to type any questions in the chat box. And at the end of the session in question and answer time, you can also take yourself off mute and ask for questions. Your feedback is important, so if you could take the time to complete the event survey, the link is there, and I'll mention that again at the end of the presentation. So let's get started. Hi, Wendy, who is our presenter for this evening. I will hand straight over to you. Thank you.
Thank you so much, Helene, and welcome everyone to tonight's session on triage in general practice. It's great to see so many people taking the time to attend tonight. So I will do my best not to disappoint you with the content. I would also first like to begin by acknowledging the traditional owners of the lands on which we are all virtually meeting tonight, and to pay my respects to the elders, both past and present, and I extend that respect to any First Nations people with us tonight. So let's get started. There's lots to cover off, and I don't want to waste a second. So, triage in general practice. At the end of tonight's session, you should be able to describe the basic principles of triage and the importance of appropriate documentation when you are dealing with your patients. Identify the robust need for practice policies and procedures to ensure that triage guidelines are followed and your patients have access to care in a timely manner. And of course, to recall the benefits of specific triage tools that you can use with your practice to ensure that your patients can access care appropriately. So the ability to confidently perform triage is a vital skill to possess in general practice. Reception and nursing staff need to rapidly and correctly determine the priority in which patients are seen within their practice based on the severity of the presenting symptoms. They need to be able to extract quickly the relevant information from a patient in order to ensure that patient receives appropriate care in a timely manner. What is triage? So the history of triage, the term triage is derived from the French word trier, which basically means to pick or sort. And that's what we do. We are given information, we pick through it, we sort out what's important, and we offer appointments appropriately. Triage systems were first used during the Napoleonic Wars in the 18th century to prioritise medical care. So what is triage? It's a rapid, systematic process to determine a person's level of urgency at the point of entry to the service. All staff need to be skilled in the process specific to your organisation to ensure consistency among staff is maintained. Triage is not just about those emergency presentations though. We are doing it every day, sometimes multiple times for the same patient, depending on whether their condition changes. The use of appropriate questions will assist the staff to ensure that they are guiding the patient to the right care. Triage is a skill that's learned over time, and staff new to general practice will not always have the same level of competency as someone who has worked in the industry for many years, where they have learned what can potentially be a serious or life-threatening condition. It's not something that we are born with, basically. So what are the different types? Face-to-face triage is obviously the easiest, as you can see the patient and you're able to identify significant signs such as shortness of breath, or they're pale, or they're clammy, or they just generally look unwell. Then you have the telephone triage, probably the most difficult, as you can't see the patient, and often the information that you're being given can be given by someone else. So it's a third party presenting you with information that's secondhand. So it's more difficult to manage patients over the phone. Waiting room, obviously patients in the waiting room may need to be re-triaged if their condition deteriorates. So having signs that tell the patient to present to reception if they feel worse or their condition deteriorates is important. So that allows you then to re-triage, to perhaps move them up the line a bit, or change the way they're going to access their care. And then finally, the post-consultation triage, where a patient is asked to wait in the waiting room after a vaccine or a minor procedure or blood collection, and you have to watch them. So as a receptionist, our role is to ensure our patients in the treatment in the waiting room are constantly managed and reviewed to make sure that they're okay. So 4 different types, along with the fact that we are basically triaging everything we do every day. So why do we need to triage? If anyone, this book, I actually found this picture, and this is actually a snippet from a practice diary from August 1983, where the only tool a medical reception required was a pencil and a rubber. Now we find reception staff often spend more time telling patients why they can't have an appointment than giving them one. So what's changed? Why is there so much demand on general practice on a daily basis? General practice has grown as the forefront of care in our communities. Appointments cannot keep up with the demand. We're experiencing patients being discharged from hospital earlier. So 20 years ago, if you had a baby, you're in hospital for 2 weeks. Now you're in hospital for 2 hours. So there's an early discharge, leaving the burden of care back on general practice. Chronic disease prevalence. As you know, it's a huge chunk of our daily interactions with patients, and chronic disease is becoming more and more prevalent as our society ages. Pandemics, I dare say the P word, so pandemics or any type of outbreak within your community where people, all of a sudden 100 people get sick on the one day and all looking for appointments. We are now the forefront. So primary care is by nature more accessible. You go to a hospital, you sit for hours waiting, and then you keep getting triaged back and back and back. Whereas general practice, your patients are pretty confident that when they ring and if they need to be seen, that they can have something in an appropriate time. We're more accessible than emergency rooms, and patients don't have those long waits. As I mentioned, the ageing population has had a significant impact on general practice. And let's not forget the workforce shortage. So not having enough GPs to meet the needs of our ever-growing community. So just some points up front. Reception are constantly trying to meet the needs of the patients and can often spend considerable time trying to book an appointment around the patient's other commitments, such as work or family. It becomes more of a social process. Having limited appointments available each day does not always meet the demands of the day, so being able to prioritise appointments is essential. RACGP standards for general practice identify the need for the provision of triage training for your staff hence why you're all here tonight. So thank you. And practices need to have policies that clearly identify the process your practice takes in the triage process, and all staff need to be seen to be adhering to this. Ensuring all staff are involved in the development of your triage guidelines ensures safe and appropriate triage is performed at all times. I'd like you to consider the following scenario. A mum rings at 10 o'clock Monday morning. My son has a high temperature and a rash on his arms, and I need to see a doctor today. Would you be able to accommodate this patient? Do you keep emergency appointments? Do you have a process in place to manage the needs of unexpected presentations? So, would you have an appointment available? What questions might you ask this mum? So, I'm going to give you an example. I took exactly this call a few years ago. Same scenario, exactly the same wording, hence why I used it. By me asking a series of a couple of questions, I was automatically able to triage. So when you have a son with a high temperature and a rash, you're thinking of a sick baby with query, meningitis or meningococcal or something really significant. So I said to mum, okay, mum, how old is your son? Oh, he's 35. Okay. So that straight away deemed it less important for me. Straight away, I knew I wasn't dealing with a young child. I was dealing with an adult. So as you can see, by asking just a couple of questions straight off the bat, you can actually already have an understanding of where this appointment is going and what's going to be possible for you to manage on that day. When we look at the types of appointments that are requested on any given day, the most common reasons people ring for an appointment are medical, so chest pain, breathing difficulty. They're obviously the worst scenarios, but anything medical. You then have the administrative types of requests, so a new referral or a medical certificate. We have the therapeutic requests, so repeat prescription, they run out of medication, they want an X-ray form. Then the logistical. This is the most difficult because it's when it's convenient for the patient. So you say to the patient, okay, I have a spot at 2 o'clock. Oh no, I can't do that. My son's got volleyball. All right, what about 3 o'clock? Oh no, I've got to go to the to get my eyebrows done. What about 4 o'clock? So it becomes a real issue trying to agree on a time. Then there's the emotional type. So someone who is looking for reassurance or support. They're the most difficult to triage. It could be someone who's lost someone, someone has passed away, or they're having significant personal issues and really need to see a GP. So what are the barriers for accessing appointments? Unfortunately, staff retention, particularly in rural and remote areas, is becoming more and more difficult. Not having enough GPs to meet the needs of the community is prevalent. There's the clinical risks. The level of experience your practice staff has can vary, and with experience comes knowledge. However, new staff, particularly if they are young, often lack that knowledge or life experience and therefore are at risk of missing something or not understanding the potential severity of patients presenting symptoms, usually as a result of minimal or no training or access to policies and procedures to guide them. Litigation. Lack of confidence to make a triage decision due to the fear of getting it wrong. There's that pressure of if I get it wrong and something happens, am I going to get sued? So that's an underlying theme. And we are going to talk about that a little bit later because that is a real risk for us performing triage that we may miss something. So what is your role or what, and I believe I'm talking to mostly receptionists tonight and maybe a few nurses. So I am focusing a lot of it on reception team, but of course it's all relevant to nurses as well. So staff need to know what their role is within the triage process and at what point they should hand over the patient to a clinical team member. Again, having a clear policy to guide them will ensure roles are not blurred and the patients are dealt with appropriately. We also need to consider the location of the patient. Are we the closest service to them, or should we be referring them to a service closer to where they're located? Consideration around what other services may be available. So for example, someone may call with a foreign body in their eye or vision changes. That may be better managed by referring to an optometrist, or a patient calls with a severe toothache. Perhaps a dentist is more appropriate. So having options for your patients is not saying, no, we can't see you. It's saying, I'm sorry, we're fully booked. However, I believe that an optometrist might be a really good resource for you to try and access. So giving them some options as well. Knowing when to seek the support of the clinical team is vital, and staff should feel supported by each other. Knowing that the clinical team will step in when reception have reached their limits of their management capabilities. I've taken as far as I can. I don't know what to do next. I need to hand this over to the next level. Non-clinical staff should never offer clinical advice. So no saying, oh, look, you know what, just take a Panadol, have a lie down and see how you feel in a couple of hours. As a non-clinical staff, we are not permitted to provide any type of clinical advice at all. Okay, documenting. So we're going to cover off this also because this is really important. Accreditation standards require it, and it is also a way of recalling a situation in a month, in a year, if something becomes of it. So when we're looking at triage guidelines within our practice, they should be simple and easy to understand. This alone will improve the receptionist team's ability to triage. They should be placed at their workstations and clear of any obstructions. So many times I've been to practices where I've asked to see their triage guidelines and they're pulling all their pads away and moving things around to find them buried beneath all their other work. So they're not even visible to them as a resource when they need it. They should be always updated, ensuring that the most common presentations are included and how they should be triaged. When we talk about suggested actions, they are simple, common sense information that staff may give to patients, particularly if there's a delay in accessing care. So what do I mean by that? They're basically non-clinically guided suggestions. So, for example, a mum rings or patient calls and they've burnt themselves or their child has burnt themselves with hot water. So saying to that patient, before you come down, how about have you immersed that area in cold water and keep it there for as long as possible? Explain to them that putting a burn in cold water will actually reduce the severity of it. I'm recalling a situation a few years ago again, and this is really relevant, where a young mum, first baby, the baby had burnt themselves with, was sitting on mum's knee and pulled their tablecloth, and the cup of tea that was sitting on the table had gone all over the child's legs. So she rang beside herself, was told to come straight down, and she came back down, and the nurses said to her, now, how long did you run, how long was it in cold water for? And she sort of stopped and said, well, cold water? No one told me to put it in cold water. So what is common sense to us when we are functioning is common sense. But when we are distressed or, overwhelmed, common sense can fly out the window. So it's always good to have those common sense advice that you can give to a patient. The other one is when a patient's having difficulty breathing. A simple suggestion is for the patient to sit upright if possible, and avoid lying down to assist with air intake. So they're not clinical, they obviously are actions that should be created by your clinical staff, and the wording should be provided to reception staff with training provided around that. So if you get a patient with burns, these are the things I want you to say to them. No more, no less, just these things, okay? So that gives reception particularly a guide as to what they should be telling the patient, particularly if the nurse is busy or if there's no one who can take that call immediately. While they're waiting, they could actually be doing something that can, reduce the impact that injury may have. So I talked a little bit before, I mentioned before, document. I'm going to explain to you now why. The standards, the RACGP standards state that we must document incidents where we have triaged a patient to substantiate the information provided during the course of triage. So what we said and where we got that information from. We need to record what the discussion was with the patient and what outcome occurred. For example, patient having chest pain, ambulance called and transferred to hospital. Or patient refused to call the ambulance and hung up on staff. So those kind of situations particularly need, I'm not telling you have to document every single phone call that you take. I think you need to document the ones where you have to provide specific triage instructions and the patient either doesn't adhere to them, or you believe they're misunderstanding what you're saying, or where you believe the outcome could go one way or the other. So it could turn bad. So these are the important cases just to document, and I'm going to show you a little bit later a really simple form that I'm happy to provide to you that you can just have at your front desk. The other benefit to that form is that if a cancellation comes in later, you're able to go back to your form and look at that patient and ring them and offer them an appointment. So when you can't offer someone an appointment immediately, always finish the conversation with a disclaimer. So I have booked you an appointment at 2 o'clock today. However, if anything changes or you are concerned in any way at all, please call me back and I will do my best to see what I can do. We'll see what else we can do for you. What this does is take the onus off you, the receptionist, because you said no, and puts it onto them to make that decision. Okay, I'm going to call back because they said to, and I'm really worried. And if the patient does call back, we need to then see them or try and manage getting access as soon as possible. So how does triage work in your practice? Do you have policies and procedures? What guides the decision making? So I just want you to reflect on that for a minute. What guides do you have to help you make decisions in relation to the scheduling of non-urgent and urgent appointments? Are there agreed policies? Do you have a policy? And if you do, when was the last time you read it? Where is it? Has it been updated? And what are the procedures and protocols in place around triage? So something, a bit of homework perhaps, to go back to work tomorrow and look for your policy, have a look at it, see what it says, and ensure that you are following the policy when you are dealing with patient interactions. Now, we'll have a quick look at what the standards say, because I did mention previously that the RACGP standards specify that we must have a triage policy. So basically, if your practice is accredited, you are required to have a triage policy. They are written when accreditation is undertaken, but they often get forgotten about. Not only should you have a policy, but your staff must be trained in how it works and how they provide access to patients by the use of triage. The policy should include the process. How do we determine urgency? What factors do we consider? When and how to seek medical treatment. So once you have determined the category of urgency, you then need to have a guide to when, how soon, and at what level do they need to seek treatment, and how the practice manages the patients with urgent needs. So these are accreditation requirements, and these 3 points should be included in your policy. And of course, what to do when clinical staff are not available. So my practice is open 7 days a week. So I have a Sunday where I have 2 GPs and 1 receptionist. I have no nurse. So the receptionist who's working needs to know what she can do if both the GPs are tied up and can't take a call, what processes or what's available to him or her at that time when they can't take the call. GP Criterion GP 1.1b states our practice has a triage system. And under that, it says you must prioritise patients according to the urgency of or need and retain evidence of this. So this is where that form that I was talking about before or you may have access to patients' records where you can quickly type a note in to the patient's file with an overview of what happened and what the outcome was. You must have triage guidelines at the reception area. You must have a triage flowchart available, and we're going to look at some examples of those. There must be signs displayed in the waiting room advising patients that if they are feeling worse or they feel that they are deteriorating, to present back to reception. And you must also show evidence that the administrative staff update the patient waiting list if there has been an emergency. So by that, I mean that you may have to move patients around. So putting notes on the appointments, move to 3 o'clock, or patient phone to come later as doctor running behind due to an emergency. So looking at that evidence that you are actually putting those processes into place and how you are actually doing that in your practice. It also says that our recorded phone message advises patients to call 000 in case of an emergency. I don't think I've ever rung a practice that doesn't have that on there as the first part of their answering service. Always ask patients when you answer the phone and intend to put them on hold if it is an emergency. So, good morning, Somewhere Medical Centre. This is Wendy speaking. May I place you on hold if it's not an emergency? Don't just go clunk and put the phone on hold. You need to wait till that patient responds by saying, no, you can't hang up. I need to speak to someone. Or yes, that's fine. I don't mind waiting. The practice team needs to be able to identify patients' needs and provide appropriate care in order to treat patients effectively. And patients need to be referred to the right clinician to receive the right level of care within an appropriate period. So this is where triage really comes into play. So this is straight from the standards and it's relevant to all general practices. And of course, we must show how practice with patients with urgent needs are seen quickly and how they're seen. And the final criterion I'm going to mention is around education and training for non-clinical staff. And the standards state that our non-clinical staff complete training appropriate to their role and our patient population. So not only triage training, but cultural awareness training, other types of training that can assist you in the process of identifying emergencies. Our administrative staff can provide evidence of training. So a certificate that you're going to receive tonight is a good start, but there's also lots of other resources you can tap into around training, even training within your practice. Administrative staff have a vital role in the provision of safe and quality care to our patients and therefore require training appropriate to their role. We can't expect a receptionist to sit down at the beginning of a shift and know all the answers. So giving them guidance and policies and procedures is so important. And a practice that supports education and training of non-clinical staff does foster that continuous improvement and risk management. So it's really important to have those for both of those things, ensuring that our staff are trained, but that we are avoiding risk management by having systems in place. So when handing over to the clinical staff, you're asking questions that will best assist our clinical team is important. Appropriate handover, particularly to someone who is seriously unwell, or can actually prevent any important information being missed. By that I mean, so you speak to a patient and they tell you in that short conversation that they're having palpitations. However, they may forget to tell the nurse this. So with all their, the confusion and their anxiety, they may actually forget to tell the nurse. So you being able to hand over quickly to the nurse what the patient has told you will certainly help the nurse to get that conversation going quickly and have the information in front of it, or to hand. So consider these statements. I'm a receptionist and I've got a call and I buzz the nurse. I said, I've got someone on the phone with stomachache, and I just hang up. Okay, so the nurse has to basically start from scratch, doesn't she? She doesn't know who she's talking to and where their stomachache, what the symptoms are. However, I could also say, I have a 25-year-old woman on the phone who says she's had abdominal pain for 3 days, some diarrhea, and now she's vomiting. So straight away, the nurse has a really good understanding of what the patient's symptoms are, so she can now move on to ask appropriate questions to further determine what that patient's needs are. Another example, I have a patient on the phone who's burnt himself. Okay, so where, how, when, versus I have an 18-year-old who has burnt himself all over his legs with boiling hot water 2 hours ago. Okay, or that same 18-year-old who has burned himself on a motorcycle exhaust pipe 2 weeks ago. So as you can see, straight away, the process of triage is kicking in, and we are determining level of urgency based on all of the information. If we just had an 18-year-old who burned himself with water, we would be like, oh my gosh, they've got to get, we need to get them down here, or they need to get in cold water. If that 18-year-old burnt himself 2 weeks ago, cold water is not going to help now. So hope that makes it a little bit clearer about why we need to get that information before we hand over to our clinical staff to ensure that they can then start the process going with more information at hand. I do want to talk quickly about a policy. I get a lot of requests about what should my policy look like. Does it have to be a 25-page policy, or can it be something, straightforward? Absolutely. Something that meets the needs of your practice, not mine or not the one down the road, your practice. So as far as the content of policy goes, the first thing you need to do is have a purpose. What is the purpose of your policy? What is the aim? The policy, and you could use something like, this policy is designed to ensure effective triage processes and principles. Simple as that. That can be the aim of your policy. Then you look at what the scope of your policy is. Who is involved? You could say this policy applies to all members of the practice team, including, and then you list GPs, nurses, receptionists, whatever. So scope of practice, scope of the policy basically encompasses the whole practice. Then you've got the statement. So this is basically, I'm just working through a standard policy and what the headings would be. Your policy statement outlines the content of the policy. So to reduce the risk to patients and comply with the RSCGP standards, all patients seeking care from the practice are subject to specific and appropriate triage processes and procedures. And you could continue on. That is more than adequate, though. What I've just said there is more than adequate as the statement of your policy. With your policy, you then need to create a step-by-step introduction to the actual policy. So this is where you'll put all of the scenarios, what is urgent, what is semi-urgent, what is non-urgent, and what the requirements are for each of those levels of care. Then you'll put the responsibilities. So you need to define the responsibilities of each discipline. So what the nurses will do, what the GPs will do, what reception staff will do, including the practice manager. And finally, the procedure, which is basically documenting the procedure from beginning to end. Always have a review date at your policy, and it should be reviewed yearly. So as you can see, a really quick overview of what a triage policy could look like in your practice, but certainly not a difficult thing to create if you get the whole team involved. So getting the whole team involved is exactly what should happen. When you're creating a triage policy, you should involve input from all staff. You need to schedule a meeting. So this is a nice suggestion. If you don't have a policy, or if you're thinking about reviewing or updating your policy, this is a really good way to work through it. Schedule a staff meeting with the intent of creating your triage policy. Ask each team member to list examples of different triage presentations and bring along to your meeting. So receptionists will certainly probably be the most valuable at this stage, because they are the ones who deal with all of the triage presentations, or they're the ones that start the triage process off. So they're the ones most likely to be able to help with all the different possible scenarios or regular scenarios that they deal with. Discuss and develop an accepted list. By that I mean, what are accepted policies? So what are we going to do? What are the accepted conditions, and where are we going to place someone in our triage? So your triage policy can't be 100 conditions wide, because it just will be unreadable and unmanageable. So basically decide on the list of the most accepted presentations that you want dealt with in each category. You then need to discuss what is the appropriate management, for example, for a patient with chest pain, or a patient presenting with query anaphylaxis, or a patient with a fracture. So looking at each of those and explaining in the policy how each of those conditions or each of those scenarios will be managed. And then the most important thing is to develop your series of questions for the reception staff to use as a guide. If they don't have a guide, how are they going to know what to ask? So it's really valuable to develop some questions that are practice specific and help your reception staff or us as receptionists to manage that policy. The policy should be initially written in draft format. So a first go at it with the goal, keeping the goal in mind. So keep your goal in mind, use simple language. Don't make it a policy that someone picks up and reads it and goes, I don't even know what this means. Simple, straightforward language. Ensure all staff get a copy of the draft and ask them for input or feedback. Is this suitable? Do you feel comfortable with this? Is there anything we could improve? Once you've completed your policy, make sure it's available for all staff to read and sign off as reading, because that then ensures your staff or the practice staff are saying, yes, I know the policy, I've read it, and I have now acknowledged that by signing that I've read it. And then, of course, set your review date. Obviously, if a significant thing happens like pandemic or a change in the way we do things, clearly we need to update our policy to reflect the current changes. So just some key points around a policy before we move on. A triage policy should be simple, specific to your practice, and easy to read. It should involve input from all your staff, reviewed regularly, particularly, as I said, if an incident recurs as a result of your process. So if you have a process that goes wrong, you need to bring it back, look at it, and change the process, because sometimes we don't always get it right, and when what's on paper doesn't always work in real life. So making sure that we review it if an incident occurs as part of that process. Include a series of specific questions that are asked to determine how urgent this presentation is, and be provided to all staff, and included on induction of new staff. So new GPs to your practice, because everyone has a role, new nurses, and of course new receptionists should have this given to them, and they must be asked to read it. And it should be reviewed yearly, and if you update it, the policy should be passed around to be reviewed. One quick slide, triage policy can become a quality improvement activity. If you're looking for quality improvement activities, it's a really great way to show that you have, you've updated. It doesn't have to be you didn't have one. It could be that you decided that your triage policy was not up to scratch, needed more work. So we have decided to make it a quality improvement, and this is what we did. So as you know, quality improvement is basically a system where we regularly review refined processes to enhance patient health and quality care. Quality improvement do lead to positive change, and creating and implementing a practice-specific triage policy is a quality improvement. So I won't go on any more about that, but keep that in mind if you're looking for, this is a really good quality improvement to undertake. Look at your policy. Does it need some work? Make it an activity that you can work on to improve. And the RACG preferred method with quality improvement, as we know, is the PDSA model. So keep that. And PHN are also a really valuable resource when you're doing quality improvement activities. They may even have a PDSA for you that you can use to get this process going. Okay, so recognising and prioritising care. So now we're going to look at how we recognise what care is urgent and how we prioritise that care, specifically around using tools, practice triage tools and our guidelines. The first thing I want to really talk about is how the impact of your appointment booking can actually make the triage process more difficult. By that, I mean, if you're fully booked, you are going to start the triage process from day one. If you start the day with no appointments, you're going to have to triage every call. Ensuring you have allocated some appointments each day to deal with urgent requests ensures care can be provided in a timely manner. We need to accommodate for all types of requests and should ensure we have both single and double appointments available so that we are not putting pressure on our GPs as they potentially will get behind if they're seeing someone extra. They may miss their break, they may not get lunch. Being flexible, different times of the day, so don't just book all your on the days in the morning, have them scattered out. You know, I call them on the days, you might call them emergency appointments, whatever it is that you save for the day of, you know, that today. Make sure there's different times and male and female GPs if available. So you might have plenty of appointments, but the patient may be requesting a female GP. So, and you may only have all your appointments with a male. If we are constantly overbooking our GPs, this can lead to no breaks, working through lunch, staying late to catch up. This has the potential of burning out our team, and we don't want that. So we need to really look at protecting our team. And I often call my receptionists like the gatekeepers because they manage, they look after our GPs and ensure that they are not overworked or overwhelmed. So we place such a huge burden on their shoulders. So why is there a lack of viable appointments? We did touch on this briefly, but as you say, as we all know, workforce shortage. And sometimes, no matter how many GPs you have, there's never enough. Increased level of absenteeism due to illness, for example, COVID or any kind of, you know, respiratory bug where there is a potential for, you know, infection. The increase in vaccinations. So, you know, the increase in preventative vaccinations. We're dealing with patients with shingles vaccinations and RSV and COVID and flu and MMR and all these added requirements on us that are taking a burden, you know, placing a burden on our available appointments. Insufficient triage skills leads to non-urgent bookings being made or taking priority, leaving nothing left. We need to offer appointments relevant to the patient's need, such as, for example, flu vax scripts, referrals do not necessarily need to have an appointment today. So sometimes the triage process starts with every call without even realising it. Patient wants a script. Do you need that script today? Oh, no, I don't need it for a few weeks. Great, can we book that next week? So asking those questions instead of just saying, yes, I have a 10 o'clock available, no problems, I'll take that. Oh, today, great. And you straight away think, oh, damn, I probably got to put them off. So asking those few questions, do you need that flu vaccine today? Is it something you have to have today? Or could I offer you something tomorrow? So just looking at trying to maintain some availability just in case. And GPs can always find something to do if they don't get booked. If they have just one appointment that's kept as an on the day and it doesn't get booked, I can guarantee you they will find something to do. So consider some following. These are solutions that I have put in place over the years. They may or may not work for your practice. So please don't think I'm saying this is what you have to do. This is just some things to perhaps consider if you are finding that every day you are booked out, or particular days that, you know, perhaps a Monday or a Wednesday, you just always have no appointments. So consider things like putting routine procedures or appointments to another day other than your busiest. So things like cervical screening, chronic disease or care planning, ear syringing, childhood immunisations could all perhaps be done on one of your non-busy days. Now, I know that's a lot of people are probably laughing at me when I say non-busy days because there's no such thing at the moment. But if you have a day that's quieter than the rest, perhaps try directing some of those appointments to those days that you find you have plenty available. You could perhaps roster one GP each day to just manage phone calls, give them a set of time and put all those phone calls into that one GP, for example. This could be done if you have a treatment room. The GP could work from the treatment room, seeing patients that present for dressings and things, freeing up other GPs' time, and they could do that on a rotating roster perhaps. As a rule, a good appointment book should be 70% of appointments have been booked in advance and 30% of your appointments are left for on the day. It's not a lot. If you have 5 GPs, you're basically looking at keeping 3 or 4 each morning session and the afternoon session per GP. It at least gives you something to start with, doesn't it? Because if we start the day with no appointments, then the triage process is already going to start. And triage should be a last resort when you're fully booked, not first thing in the morning when you haven't had a chance to have your first coffee. So where do we begin? What's the bottom line? Does the patient need to be seen urgently? That is the underlying question when you are performing any type of triage. So this is a really simple diagram, which I will send through to you. It basically sums up everything in one simple flow chart. You ask the question, are you calling about an urgent problem? How the patient responds will depend which flow chart you follow. Yes, I am. Okay, can you tell me the main problem you need to see the GP for today, please? Now that patient will either say yes and give you a very long-winded explanation, or they might say, no, I don't want to tell you that. It's none of your business. So that becomes more difficult, particularly if they're going to say no. But if asked why, you need to say to that patient, and you can use your own prepared statement, but what I would say to that patient is, in order for me to be able to provide appropriate access to care for you, it would be easier if I had a little bit of an understanding of what it is that you need to see the GP about. So I don't want to know all the details. I just want a brief understanding of what it is so I can help you. That really works because patients think, okay, she's not a busybody. She just wants to help me. If that patient says, then you would obviously consult your triage guidelines. If the patient has said, yes, it's urgent, and then look at your appropriate actions depending on where they fall within your categories. If the patient replies, no, it's not an urgent problem, and then you could say, are your symptoms causing you any pain or distress at the moment? Yes, they go back over to the orange side. No, okay, make an appointment however, I'm going to make an appointment on Tuesday at 2 o'clock. However, in the meantime, if your symptoms become worse or you are concerned, call straight back. So there is that disclaimer that I was talking about before that removes the responsibility back to the patients to contact you if things change, because you don't want them to think, oh, they said no, and that's all they said. They actually said they didn't have anything, but I'm welcome to ring if things change, so I'm going to. I do want to talk to you about clinical justice and vicarious liability. So clinical justice ensures access to an appropriate level of healthcare that is both timely and in line with the patient's current needs. If a practice does not have guidelines in place for prioritising a patient, so you don't have a practice policy or tools that the reception staff can use, they may be liable for the negligent act of their employees. If the employee does not have practice-specific guidelines to follow, this is known as vicarious liability, and we must ensure that our reception staff or us as receptionists are trained. So I'm going to briefly describe where all this come from. When was the introduction of triage in general practice first implemented? So it goes back to a Supreme Court decision in 2001 against Mr. and Mrs. Alexander and Dr. Heiss. So I'm going to give you a quick overview so you can just comprehend what it means. On the 4th of March 1996, at around 2 o'clock in the morning, Mr. Alexander woke his wife complaining of a severe headache and asked his wife for some of her migraine tablets because the Panadol wasn't even touching it. He took the tablets and went back to sleep. The next morning, Mrs. Alexander told her husband she would make an appointment for him for a full medical because she thought, he was under a lot of stress, and Mr. Alexander agreed. The headache had subsided and he went to work that day. That evening, Mrs. Alexander attended her GP, Dr. Heiss, and after her appointment, spoke to the receptionist about making an appointment for her husband for a full checkup. He was not a patient of their clinic at that stage. She explained to receptionist that her hubby had a severe headache last night, and this was really unusual for him, and she just wanted him to have a checkup because she really thought he was under a lot of stress. And Mrs. Alexander advised her that he had gone to work that day, so he would prefer an evening appointment where it won't interrupt with his work schedule. The receptionist offered her an appointment 1 week later at a suitable time, which was booked. The day before Mr. Alexander's appointment, his wife found him unconscious in bed. He was transferred to hospital where he died from a ruptured cerebral aneurysm. 2 years later, Mrs. Alexander commenced legal proceedings against both the GP and his receptionist. So why am I telling you this? I want you to be aware of the implications of ensuring we follow the practice policies. So under the Supreme Court found that there were questions raised. Did the GP owe a duty of care to this patient he had never seen before? The GP said there was no doctor-patient relationship. I didn't owe him anything. The court found that once symptoms were described to the receptionist and an appointment was made, Mr. Alexander became a patient of that clinic and was owed a duty of care. Did the receptionist owe a duty of care to Mr. Alexander? The court held that there was a duty of care to ensure that a patient with possible urgent medical conditions should have been either referred elsewhere for treatment or given an earlier appointment, and that the receptionist be trained in how to determine urgency. Was the GP liable for the actions of the receptionist? As I said before, when an employee commits an act of negligence during his or her employment, the employer is vicariously liable. And finally, did the receptionist and or the GP breach their duty of care? The court held that the receptionist could not have appreciated the life-threatening condition on the information provided to her. The patient was well enough to go to work and had asked for an evening appointment. So the reason I'm telling you this is purely to be aware that we have got policies and procedures, and if we don't follow them or aren't aware of them, there are medical risks. There are possible medical legal risks as a result of that. So the process, what do we do? So in the morning, do you turn your phones over at opening and just book until you're full? Or do you triage every call to determine exactly how urgent it is and could be potentially booked on another day? By asking the right questions, you may be able to actually direct that request to another day or another service, which may be more appropriate for the patient's needs. If you're fully booked, what is your procedure? Do you say, I'm really sorry, we're unable to assist you today as we're booked out? Or do you double book the doctor, or do you squeeze someone in here and someone in there? Do you ask them, do you need to see someone today, or could I offer you something tomorrow? Do you direct them to a more relevant service provider? As I've said more than once, asking questions puts the onus on the patient to actually identify the urgency. Also, you need to remember, everyone has different perspectives. So what I think is not urgent, the patient may feel is urgent. We cannot dismiss their concerns. When we look at triage, the process of a non-urgent appointment, what does it mean when the doctor says book a non-urgent appointment? It's basically booked according to the level of urgency. So if the doctor is saying non-urgent, it's between 24 to 48 hours is acceptable, but anything up to a week is okay. You could also offer the patients a cancellation list appointment. So book them in a week, but offer a cancellation appointment, particularly if they're being recalled and a bit worried about it. When there is an urgent appointment, or when you are required to, you're trying to book an urgent appointment, you need to follow your triage tool to determine the appropriate time for access and then book that appointment appropriately, even if it means double booking. And don't forget, always end with that disclaimer. When you are taking calls, as I said, when patients are calling the practice and you are busy, always ask them, is this matter urgent, or may I place you on hold? Wait for them to reply before you put them on hold. Use your practice recommended questions to quickly extract from the patient what their needs are. This will then determine whether the call needs to be transferred to the clinical team or whether you are able to manage it. By actively listening, you will be able to pick up on cues that will help you decide what's actually wrong and what's it needed. For example, my mum fell over last night and hit her head, and now she's complaining of a headache. What type of questions could you ask? Okay, how old is your mum? Did she lose consciousness? Is she able to tell you what today is? Is she orientated to time and things? And does she have any other injuries? They are 4 simple questions that you could ask that would allow you then to determine how urgent this may be. This will give you a better picture of what happened to the patient and what may need to be done as far as care goes. And it will give you a really good handover to your clinical staff. So, I just did that. The other thing I beg your pardon, I have repeated that. So is this an urgent matter? But also the demographic details. Where are they? Are they at home or are they elsewhere? Is there a service available to them that's closer to them than what you are? They could pass 5 major hospitals on the way to seeing you. Ascertain the nature and severity of the problem. So ask them, what is the problem and how severe is it? How long you've had it and is it getting worse? Then act and advise according to practice protocols. Make sure if they are alone, ask them, are you alone? Particularly if someone's calling with chest pain, are you alone or is there someone with you at home? Always close your discussion with an agreement on how you're going to proceed. So I'm going to book you an appointment for 2 o'clock today, or you're going to hang up and you're going to call the ambulance, or you're going to hang up and I'm going to call the ambulance and then I'm going to call you back. So give them finish that conversation with an agreement of what's going to happen and document that decision either in the patient's clinical notes or on a triage form that I'm going to show you. There are recommended actions. The most common, call an ambulance. These are the kind of things you're going to see when you're triaging on your tools or on your policy. Calling an ambulance for those significant red flagged symptoms, directing a patient to the emergency department or to an urgent care centre. We're fortunate enough to have a lot of those around us now. You may need to discuss the problem with a GP or a nurse immediately or within 30 minutes, sometimes within an hour. Advise the patient to come to the practice now and inform the clinical staff when the patient arrives. Make an appointment for the patient today or make an appointment in 24 hours. So these are some of those recommended actions depending where they fall on your triage category. With phone consultation, there are risks associated. While we are so fortunate to have the ability to now conduct phone consultations, we need to be sure that this is actually appropriate. We often tend to book patients' phone calls when they describe respiratory issues or concerns because we don't want patients coming into the practice coughing. However, this is not always appropriate and could end up in the patient needing to be seen anyway, and therefore further delaying care, but also putting the GP further behind because I have to see the patient twice. So by phoning, when someone phones, the doctor can't examine them, they can't look in their throat, they can't check their ears, they're relying on what you're telling them, so it's objective versus subjective. Serious conditions can be missed, and we found that, didn't we, during COVID? A lot of things have been, still developing now as a result of patients not being able to go to the clinic. And how do we manage this to ensure care is provided? So how do we manage those patients who may have respiratory symptoms that we don't really want in the practice? So obviously there is still the option for car consults. It isn't done very often now, but there is still an option. The most popular option is having a single room that you use on isolation room, where doctors can see patients where they're isolated from the patients in the waiting room and the staff, and the doctor may be able to then put on PPE before they go in. So that's why it's really important to have that. Know that phone calls, when you're booking a phone consult, it's not always the most appropriate booking. There's been increasing feedback from a lot of specialists in allied health about experiencing long delays. We're busy, the phones are ringing crazily. Specialists ring because they want to return a call from the GP, or they want to communicate something with the GP or the nurse, or they're looking for information from the GP about a patient that they have with them. So it could be the pharmacist calling, looking for medications. How do we manage those calls? So I guess answering calls in a timely manner is important in your practice. Oh, whoops, that was funny. How we ensure access to, so how do we ensure that people like specialists and pharmacists can access the GPs? There are options besides your phone system. So what we do, when my GP is expecting an urgent call, they give the specialist the practice mobile, which sits with me, and I am then able to take the mobile to the doctor when that person rings back. A recorded message offer, you could have an option. If you are a GP or a specialist, please press 1, and that will prioritise the call to perhaps the practice manager or to the nursing staff, or the GP may want to provide their personal mobile. So just talking, I know it's not 100% related to triage, but we're looking at about access also. So this is something we need to consider. So tools, there are so many triage tools, and I can show you, I'm going to show you a few, but you really need to make it specific, and I'm going to show you one which I think will work for most practices. So this one is a really good one as far as quick, easy identification, but it's short, it's sharp, and there's nothing else to it. So to me, all I'm looking at is a patient who's serious accident or injury. What does that even mean? And what do I do with that? There is no guideline. So this is one you would avoid. This one, however, is available. I'm more than happy to send this to anyone as a Word document, and you can then create your own pop gun. That's what they are called, Prioritising a Patient's Guide for Non-Clinical Staff, or pop gun. You'll hear it all the time. This is a really good pop gun. So it has a flow chart. So it's already got the, do you have an urgent problem? Yes or no. It then goes through to get to ensuring the person asks the appropriate questions. This is where you would add your practice-specific questions. You might want to record the patient's phone number straight away, because if you lose contact with them, you might not be able to get them back. And then you can say, what is the nature of the problem? What is the duration of the problem? And what is the severity? They could be your decided questions, or you could make up any questions that you want that match your practice. Then you have your categories, 1 to 6, and obviously we all know straight away looking at that red's urgent and green is calm. So that's the least urgent. The issue I find with a lot of these tools is that sometimes a patient's symptoms fits into 2 categories. They may call with facial swelling and rash and have had a snake bite. So they're all of a sudden in 2 categories. Always defer to the most serious category when they are describing symptoms for multiple categories. Then it gives the recommended actions. Remember, I talked about what your practice recommends for each of those definitions. Triple O for red, go to casualty or ED now, put the call through the nurse for yellow, come to the practice now for blue, come to the practice sometime today for purple, and come within 24 hours for green. So really good resource, really user-friendly, and can be specifically designed to your practice, because I'm happy to provide you a Word document. This is the basis from where this was taken. This document is no longer available on the internet. It was basically used by everyone. So this is where the information came from. However, what I like about this one is the back of this. This is basically a triage policy. So you could use this to guide your decision making. So happy, you'll get a PDF of this slide, of all these slides. So you'll have a copy of this. You can use it to add to the back of the one that you're going to get that you can adapt. So really valuable to have these guides, because these are what are going to make your reception staff feel more confident when they are, or you as receptionists, feel more confident when you are dealing with a triage situation. When you use the triage tool that I just showed you, they're the kind of things you need to remember, that the tool must be specific and meets the needs of your practice. It needs to list what the presenting symptoms are to be included, a time frame for the person to be seen, recommended actions, ensure clinical staff have input, and if you are not confident or unsure of your decision, always defer to a clinical team member. So if you as a receptionist don't feel comfortable, or you think this is above and beyond your scope, you will then refer it to another team member. Red warning flags that we should all be aware of. These are the things we really need to be conscious of. Anyone having issues with their airway. So it's the same old ABCD. Remember that from your CPR. It's basically the same things. Airways. Are there any issues? Are they choking, or are they having problems swallowing? Problems breathing, chest pain, chest tightness, right through to circulation. So bleeding, drowsy or alert. Can they speak or can they not speak? Have they got a headache? Disabilities, so problems moving, they've got left-sided weakness, or they've got pain, or they've got speech problems. All those things, when spoken, when described, can basically give us an idea of what's going on straight away. The other red flags you should be aware of are these. Fever, particularly in a child. Someone who is unwell, who has recently travelled overseas, and that doesn't just mean through COVID. Look at that picture there is of measles. So there's measles running rampant in many countries, including ours. It's not running rampant, but there is a re-emergence of measles. Allergies, patients who are having an anaphylactic reaction, severe abdominal pain, mental illness where the patient is having a psychotic episode, significant burns, eyes must be taken very seriously, particularly if there's injury or there is pain associated with the eye, unexplained rash, any kind of infectious disease, so flu, measles, COVID, any of those, and any at-risk patients, so someone who's undergoing chemotherapy or is immunocompromised, or maybe pregnant and have been exposed to RSV, for example. So looking at these red flags, you then need to agree on how you're going to manage those. This is the form I've been talking about all night. This is the form my staff have at their disposal. It's basically a contact form. So it can be as simple as complex. Mine is not. My receptionists do not fill this out for every patient. They only fill it out for the patients that they think the decision that was made could come back and bite them. I'm not really happy. I don't feel happy that I couldn't give that patient. Something about that phone call just resonated with me and I'm worried. You would document that information and you would either place it in the patient's file and call it triage from 29th of May 2025, or it may even have a folder that you'll store these in, but it's a lot easier to find in the patient's file, particularly if you're talking 2 years' time. So I don't remember what I did yesterday, let alone what I did 2 years ago. So really good resource, happy to share it, and you can adapt it to be whatever you want it to be, as small or as, as meaningful as you want it. So to finish up, I'm just going to give you a bit of a case study. I know we can't interact, so I'm going to just basically talk you through this one. I don't know why it says number 4. I must have, sorry about that. So the wife of a 78-year-old Mr. Brown phones the practice in a state of panic. Her husband is no longer able to move his right arm or leg and is not able to speak. She also notes his mouth is drooping. He's responsive but difficult to understand what he's saying. He has diabetes and high blood pressure. So, what are the key facts here? The first thing is obviously right-sided weakness. He has no strength in his right arm or leg. Slurring his words. The fact that he has a history of diabetes and hypertension, which can certainly impact on our cardiovascular system. This gentleman may have or be having a stroke and will need urgent transfer to hospital. So those symptoms described, if you're appropriate to a triage, would be a category 1, ring an ambulance right now. Do not come here, get an ambulance and get him to hospital straight away. Yeah. Then we have the husband of Mrs. Arks. She's 50 and he calls because his wife is suffering from a red and very painful right eye. She feels miserable, nauseous, and has a headache. The vision in her right eye has deteriorated and she is experiencing flashes of light. Her left eye is normal and she has no significant medical history and is not taking any medications. So again, the key factors here, a red, painful eye, nausea and headache, vision deterioration, flashes of light with the left eye being normal. If you were to ask a GP, he would straight away say either acute narrow angle glaucoma or retinal detachment. Serious, straight to hospital. So these are the kind of things we can misinterpret. Oh, they've got a red eye, they've probably got something in it, and not connect the dots. So I just wanted to give you a little taste of what could be the kind of conversations you could, and there are so many more. I could just do this all night. But basically just an understanding of what the kind of things and how you quickly extract from that data the key points. What didn't I pick on? I didn't indicate in the first patient the age, because age is important. Those same conditions wouldn't matter in any case. That's classic stroke symptoms. However, if you were not familiar with classic stroke symptoms, then you may misinterpret. So best practice triage involves policies and procedures that clearly outline steps in the triage process and the roles and responsibilities of all those involved. It should be included in practice induction or orientation and included as risk management to ensure you're meeting accreditation quality standards. Having an adequate appointment system to accommodate urgent appointments will reduce the need to triage, and having clear, effective communication skills so that you can quickly and efficiently extract information and hand over that information where needed. Having an algorithm or flowchart, POPGAN, to guide non-clinical decision-making, identifying the red flags and a prompt for what patients, a prompt to responses by reception staff, so what reception staff can say. A team-based approach that allows non-clinical staff to default to a clinical team member when needed. And of course, protocols for patients presenting with potential communicable conditions. And of the utmost importance is appropriate triage training. So to sum it all up, triage training is an essential skill for all practice staff. Following your practice policy and triage guidelines will ensure that your decisions are made with the best possible outcomes for the patients. This will ensure patients receive access to appropriate level of care in a timely manner. So there's some really good resources that I'm going to, that you're welcome to access. I'm going to now stop sharing my screen and hope to have some questions.
Thank you, Wendy. I do have some questions and some comments in the chat box.
Wonderful.
First question, what happens when clinics don't meet accreditation requirements of having on-the-day appointments for their patients and send them to an urgent care centre as an easy way to defer the continuing conversation?
So you must be seen to be shown that you are trying to accommodate. So I'll give you an example. So I use best practice. As you know, best practice, you can add what they call on the days, where they are unable to be overridden until the day. But doctors want to see someone today and want to see them tomorrow. You need to use it on the day. So sometimes we get to the point where one doctor has no on the days because we've overridden them all. If you have, remember we look back at Mrs. Alexander and Dr. Heiss, the recommendation was as long as you can provide them or refer them to appropriate service in a timely manner. So if you can't service someone today or help them, but you can offer them an option, you have met your duty of care to that patient.
Very good, thank you. I feel like it's a lot of responsibility for admin to give advice regarding medical treatment or care. Shouldn't any calls with medical questions or queries be redirected to medical staff, always to refer or advise appropriately?
Yep. And that's a very good question and a very good, as I said, this is all practice specific. So your practice might decide that in their team, they don't want reception doing any of that. It's all going to go to the nurses. And that's okay, as long as that's what your practice policy is. But you still need to understand how to determine urgency. So this is completely relevant to your role. However, you may decide that we're not going, my non-clinical team are not going to deal with anything. As soon as a request for an urgent appointment is going to get transferred directly to the nurses, and that is absolutely fine as long as that is your policy.
There was just a question, could you please share the resources slide again? We will be providing the slides and the recording to everybody. That'll be sent tomorrow to everybody. We always do that. So rest assured you'll have all those details.
And I will attach the, when I send the PDF, I'll also attach the Word document of that triage document list if you want to use it, and anything else that I think might be relevant to share with you, because there's so many resources. A really good resource to read is the RACGP Keeping a Safe Practice. So that is actually in the links of the evidence. It's a really good one to use because it talks about triage and it talks about making decisions about how you're going to actually implement a triage process relevant to your practice. As I said, I've got 22 GPs and 15 nurses, so I don't have a problem. My reception staff are fully supported. You might be a single GP practice with one nurse. It's a completely different environment, so it needs, my practice policy is not going to work for your practice and yours is not going to work for mine. It's also about what's available. If you have an urgent care centre close by, you have got that support of referring your patients to that. I think when I look at it, when you just say no to someone, that's all they remember. So if you ring up, or they ring up and say, I'm really sorry, but we're fully booked today, I can't help you. You can either end the conversation there and they're going to feel disappointed or not heard, or you could say, however, have you tried Nurse on Call, or have you tried 136, or have you tried, the urgent care centre? Then there's 3 located within I'm not sure how many you've got, but I'm just making it up as I go along. There's an urgent care urgent care centre located just a few blocks away. Have you tried that? Patients will then feel that you have given them something else besides no. You've given them options, and that's really important when you are dealing with patients, because they're going, oh, okay. It's like when you ring someone and say, no, I haven't got that, but have you tried Bunnings? Oh, okay, I'll try Bunnings. And they say, no, we haven't got it, try mine at 10. But they're giving you options, and you just keep moving through that process. So I think it's really important that we give our patients something to go forward with.
Thank you, Wendy. I think I may have answered everyone's question. I haven't got any in at this stage. Feel free to take yourself off mute and ask a question to Wendy if you want. In the meantime, could I thank Wendy very much again for a great presentation. Always a pleasure to have you, Wendy. I know how busy you are, so we're very fortunate. And I think you're back again in a couple of weeks with another topic.
17th of July, we're doing a workshop on 17th of June on My Medicare and the Aged Care Incentive and what the changes to chronic condition is going to look like. So I'd love to see you all there, because there's lots to talk about in that one.
Thank you. I will end this for everybody now. Don't forget your evaluation survey and pop in any topics or anything you would like to talk about. And thank you again, Wendy. And
You're
goodbye,
very welcome.
everybody.
Thank you, everyone. Have a good night.